So general appearances of breast on ultrasound is really different when you go from young to old, skinny to heavy, um, whether or not whether or not the patient is pregnant or lactating is also, it makes a big difference. Um, and of course, any kind of augmentation. Oh, I don't have any of that. We'll do that. We'll do that along with masses tomorrow, I guess. Um, this image here, let's see, let's get a little closer. And blue pen. Okay. This, you can tell just by looking at it that this is a young breast, a young person's breast. And just quickly look at it. Obviously, as we put the transducer down, the very first thing we see is the skin. And then we see fat layer. Now, fat on breast, and maybe it has a lot to do with the way we set up our transducer. Well, actually, no. I mean, if we look at fat in other parts of the body, tends to be a little more echogenic and fuzzy, overall fuzzy image, like the transducer, the sound just doesn't really like traveling through it. Fat in the breast is, look at it, it's isoechoic. This is muscle down here. That's pretty much isoechoic, a little bit different patterns in there, but, and also, yeah, so anyways, fat, with a T, I guess, or just fa. We have a fat layer. We have Cooper's ligaments going through. Around so those are Cooper's ligaments going from the skin down to the fibroglandular layer, and even beyond the fibroglandular layer, but we're not seeing any of those right now. And so here's our fibroglandular layer is here. And you can see that the fibro part of fibroglandular. Oh no. We're missing. I don't know. The fibrotic part, the fibro part is the echogenic. So all this is fibrotic tissue of that layer. And then there's the glandular part, so it's fibroglandular. And the glandular part is these. So these are basically TDLUs and terminal terminal duct. Oh, for God's sakes, Kurt. Terminal ductal lobar units. Terminal ductal lobar units would be there. And some ducts, like here's a duct traveling along here. And then below that is muscle. That's a decent amount of muscle right there. Once I think about it, that's pectoral muscle, perhaps pectoral laying on top of, pectoral major laying on top of pectoralis minor, but still, that's a good size. This is I work out, so this girl works out. You usually don't see that much muscle. As we come down, this patient, as this imaging is a little dark for my taste, they made the retro, I'm sorry, the pre-mammary layer. This fatty, that's the other thing it's called. It's also called Well, this layer B, the B layer here, fat also. Whew, that's pre-mammary. Sorry, just had another coffee. And then this mammary layer here is D, and then E is, well, E is muscle. What we're actually missing in this picture, whoa, I just didn't realize that. Missing retro mammary. So really, if I'm going to look at that, I'm probably looking right about there. I was, just in my head, I was thinking that's all muscle, but wait a minute, there's got to be another layer. So it's very thin compared to the top layer of premammillary. So as we come down, and like I said, this imaging is a little dark for my taste. They've made the fat almost anechoic, like in the middle here, anechoic. A little too dark for me, but well, whatever. But then from, basically here to here is our mammary layer, and what we have here is we have some ducts. The ducts are a little bit prominent. Perhaps this patient is pregnant. I wouldn't quite say lactating, but it's slightly prominent. And then let's see. Once again, we did the same thing. You know what? It wasn't my fault. It was the website. Once again, forgot the retromammary layer here. So fat, and then this is the fibroglandular. Over here, this image is it's a little grayed out, probably looks like an older machine here. But once again, skin, subcutaneous, fat, middle mammary. Well, there's no such thing as a middle mammary. It's just mammary, and that's along here. Looks like we're going towards the edge of the breast because we're running out of mammary and we're just going fat. And then retromammary, and that's also fat here. And then pectoralis, yep, muscle, and then chest wall along here, and this down all the way down here is going to be lung. Yeah.
Mr. F.
Yeah.
So does that happen as like we get older, the mammary, like it starts to turn into fat?
Absolutely. Let me turn up. I can barely hear you. There we go. Yeah, absolutely. The exception to the rule is if two things. One, nulliparity. You've never had children, you tend to hold on to the mammary layer longer. And then two, if you've never had children and you're on hormone replacement therapy, then you're going to hold on to that layer longer. But eventually it goes away. There's only so much hormone therapy you can do. Yeah, so let's see. From personal household experience, I'll put it that way. This mammary layer can be very dense, and that's actually one reason to have an ultrasound is that it's so dense, and I mean dense as in like hard, that X-ray or mammograms don't go through it very well, or what they do see is just is as white as bone is on a mammogram, and as if you were doing the skeleton, the central part of the breast, the most important part of the breast, but they can't really see, and so then they'll send someone to ultrasound just for a double check. But then that is a transient finding as far as long-term age of a patient. So when they get older, that really dense material tends to go away. Oh, just from the, they always use the same colors. I know this is Ultrasoundpedia. Great site. Let's Ultrasoundpedia. I had some trouble getting to the site for a while from school because I believe it's in Australia. And since Australia is in that part of the world where a lot of internet crime originates, not so much Australia, but other countries in that area, they Pima just shut down that entire quadrant of the globe. But I think I was able to eventually get this website back. But once again, skin, oh, skin, by the way, around 2 millimeters or less. Fat, of course, is variable. So mammary fat, yep. This mammary layer on this person, look at that, comes all the way up to the skin for a little point right there. Retromammary, well, they include in this image, all right, they're not such a good website after all. No, that's all right. Retromammary, they went all the way from the mammary layer all the way down to, they're actually well into the lung at this point because, well, they're about to the lung. So they've included muscle, ribs. Oh, by the way, ribs here, rib. So retromammary technically should just be the little fatty layer back here, and then the pectoral muscles are their own thing. But this patient basically doesn't even have a retromammary layer. It's there's really no fat behind the breast at all, or behind the glandular tissue at all. I think this is from the same site. And whoa, look at this. These ducts now are really a lot more obvious. This guy down here, and then we're within that fibrotic stroma. So this is a lactating patient. And in fact, look at it, is so swollen, the mammary glands themselves are so swollen, I'm not even seeing fat up here, fat below, fat above. There's no fat. It's just pure glandular material in this patient. But we do have to be aware if a patient is lactating, it's going to look different. Retroareolar, in other words, behind the nipple. I'm going to write something. Important. The whole breast is important, but getting behind the nipple and getting it without shadowing, which is the trick, is very important. We're going to talk about that. But nipple, I would say they're just off to the edge. Right, left, up, down. I don't know which direction. They're just off to the edge because you're not seeing the actual nipple. So they're just off to the side, and they're looking. They're probably because they're trying to look underneath. And what we're seeing here is kind of that sinus here. There's probably multiple sinuses here. It all looks like one, and then some major lactiferous ducts coming up. So this is, let's see, got milk question. Yes, we do. We do have milk. Nipple. Now we're dead center on a nipple. I wouldn't say everyone, but Well, yeah, they're kind of like snowflakes. Honestly, guys, they're all different. They all scan differently, and it really depends a lot about the structure of the nipple and you know how large it is, whether it's inverted, whether it whether I'm not joking. Well, I am kind of, but I'm not joking. Whether it's cold in the room, it's all going to make a difference on how this scans. And what they've done here, lots of gel. They filled what would otherwise be an airspace with gel. If they didn't have gel here, what would we see behind here? Nothing. We would see nothing back here. So the gel is really important here. We do have some edge shadowing, that's okay. But even with the edge shadowing, it's so important to look behind the nipple that, well, we'll talk real soon about how you roll the nipple. You go on either side of it, you look underneath it from different directions. Really important. Another image of the nipple. Here's the nipple itself. Obviously, it's being pushed down. It's not normally inverted like that. It's being pushed in. Some edge shadowing. This edge shadowing is fine, but you cannot just take this picture and be done with it. What if there's cancer right there? You know, so you got it. We always have to go around and around and around. I said lactating with a question mark because we do have some obvious ducts that we could see here, but not a lot, not a ton. So I'm not so sure. You know, sometimes on younger women, there's just fluid there. It doesn't mean that they're lactating. It's just the ducts are filled with some fluid. Oh, and there is a palpable mass 10 centimeters from nipple. Okay, two things. This doesn't belong in this picture because that is the nipple. It's not 10 centimeters away from it. And well, the other thing, 10 centimeters, that's a long distance. So I think let's see, 10 centimeters from nipple, palpable. See, this is not good. We know that it's a left breast, but 10 centimeters in that direction, in that direction, in that direction. What direction? Now, 10 centimeters, that's a large number. So we're probably talking about a large breast, but still, I'm guessing this is going to be more towards the axilla because that's the longest direction from the nipple you can get and still be in the breast. But like I said, all of it is incorrect because that's the nipple itself. So they should have just removed this from the image before they took it. Yeah, I'm just going to go through a few more pictures and then I'm going to go to my notes here. Cartilaginous ribs. Our ribs up into the sternum, so all along the costal line and those last bits. So basically the ribs that are medial are still cartilaginous even in the adult. It's not until we're much older that this becomes more ossified. So cartilaginous ribs can be if you're not accustomed to seeing cartilage. Now these are, in my opinion, these are fairly obvious. I don't think this is even a female. I think this is a male, but I just took the picture anyway. Because they could, these are somewhat filled, but they could be like super hypoechoic or even anechoic. But if you're not used to seeing them, not a mass. And the way you know that it's not a mass is when you look at it, anytime we find something like that, we turn on it. And so when you turn on one of those two, we're now going to see "90 degrees, we turned on it and we see that it lengthens out. Ah, okay, it's not a mass, it's actually a rib. So this one, like I said, this could be a male for all I know, because I don't know, I don't even know where exactly, probably is a male. Skin, fat, muscle. So there's no mammary layer at all here, so probably a male. Okay, now let me use this space here to write a few things down about what to expect when scanning the breast. Okay, appearance, I already mentioned, varies widely, old to young. Dense breasts to fatty breasts, thin, small breasts to maybe heavier and large breasts. And it makes a big difference on what we see. Skin, 2 millimeters, I already mentioned that. Oh, but skin, where are you? There you are. The skin look at it as in with your eyes, not just your ultrasound. Sometimes we learn about a patient from what their skin looks like. Unusual, especially if the patient has no memory of it being there before, a dimple or some kind of retraction of the skin is suspicious. Question, cancer. The reason being is that, let's say, here's my skin layer. Oh, and get my little cheater here. And of course, there's Cooper's ligaments traveling down. And we have a tumor here. And those tumors tend to reach out and grab a hold. They could grab a hold of the skin itself. They could grab a hold of Cooper's ligament. So if you see me on the screen, cancer doesn't stay encapsulated. It grows out. It has like little fingers growing out. And those fingers grab a hold of everything. That's why when we talk about cancer, it's, yeah, palpable. Of course, benign's palpable too. But if it doesn't move, that's suspicious. The reason it doesn't move is because it's grabbing on. So you got all these little tissue going out and it's grabbing on. And as it's grabbing on, it's retracting, pulling down basically on the skin, and then also the internal architecture will be distorted from the way cancer grows. And on the skin, it will create a little divot as it's being pulled down. And so that creates a dimple or a retraction where otherwise you wouldn't expect one. What's the other thing? Okay, well, let's see, color, texture and color, yeah. We also look at the texture and color of the skin. There's something called, let's see, Peau d'Orange. Peau d'Orange is now that's obvious. When a patient has that, you're not going to miss that. Probably the reason why they're there. It actually, this in French means the skin of the orange. And what happens is that there is massive inflammation and edema from certain kinds of cancer that causes the breast to swell, and what happens is that every single hair follicle, all those tiny, tiny, tiny little hair follicles, hopefully they're tiny, Sasquatch, but all those little hair follicles kind of stay put while the skin is edematous around it, and it kind of looks like an orange peel. So that's something else we look for. And then let's see, nipple. PLE. What do I have to say about that? Extra gel, I already mentioned. Compression and roll. Okay, so lots of gel. Lots of gel needed to look at the nipple. And we, did I say roll and compression? Compression. In other words, if you're right on top of the nipple, go ahead and push down, because you need to compress. You compress the tissues, get rid of that airspace. Yeah, you need to compress it, and then roll. So rolling, and some people, and I know those of you who know that I'm trying to be good with you guys, but I am a bit of a jokester and all that stuff. But believe it or not, I am very respectful when I'm actually seeing patients. And some people I've talked to do not do this. They feel it's they don't want to get in trouble, and women don't do this as well. But look, this is important. And in fact, how do I? All right. Well, I wanted to stop sharing the screen for a little bit, so I'm bigger on your screen. But in a professional way, you need to see underneath the nipple. Here's my phone. Is my transducer. Nipple sitting here. You try to, you can come up next to it, but all you're going to do is you're going to push it to the side, and you might not be getting directly underneath it, which is why I advocate using the back of your fingers. Now, two reasons. One, when you're using the back of your hand, it's not going to be, or it's less likely to be interpreted as touching, inappropriate touching. Also, you type with the front of your hand, not the back of your hand. So you get gel on the back of your fingers, it's not such a big deal. Gloved hand, I would push, I would hold like this, get my transducer, and roll underneath the nipple. So that's one way of rolling the nipple. Like I said, it's important. So and I've never had a problem. I've never had anyone think that was inappropriate or anything. And you always, whether you're male or female, guys, while I'm thinking about it, females, you get yourselves in trouble just as much as males, because males for obvious reasons, females because sometimes you assume, oh, you're a woman, I'm a woman, no big deal, I'm just going to go up and grab your boob because I need to. Don't just do that. Always tell them, I'm going to do this. I'm going to palpate. If when you palpate, it's not it's not squeezy. It's careful with your fingers and in a professional manner. Always tell the patient what you're going to do, especially with these kinds of exams, male or female. Okay, so, skin, nipple. All right, so okay, well, I have some other notes. They really kind of go with the images, but let me just quickly write them down anyway. The pre-mammary, so the fat, subcutaneous fat, but yeah, like over there. Mid-level echo. Little unusual for fat. Fat's usually a higher level echo, but it's mid-level. In other words, it's kind of the same echogenicity as well. The muscle, not all that different. So that's what to be expected. Cooper's ligaments. We will see Cooper's ligaments kind of encasing and surrounding the fat, and that can sometimes looks like a mass. And I would even say more than sometimes. Very often when you're scanning through, and when you're scanning through a lot of fat lobules, they almost looks like ocean waves. And every once in a while, one looks different than all the others, and it stops you in your tracks, because that's your job, is to look for anything unusual. So go ahead and stop. See, does it connect with other fat? Is it completely by itself, like totally and utterly surrounded by an echogenic fascia? Okay, if it's completely surrounded, that's probably a mass. But if it's not, if it connects, then it's fat. If you turn on it and then now it looks normal again, then it's fat. But sometimes it does. Cooper's ligaments. Cooper's ligaments, they can shadow. They can shadow. And here's the thing about shadows. If you don't know exactly what caused the shadow, it is always suspicious. Shadows deserve a second look. Always deserve a second look. Now, Cooper's ligament, if it's Cooper's ligament, you push down a little harder, and the angle of incination will change and the shadow might go away. Then you know, okay, that shadow is nothing, and you move on. But we always look at shadows. Cancer has a tendency to shadow. I have a question here about implants, and I wish I had, I don't know why, I guess because I really didn't get to it in the chapter yet as I'm going through my notes. Implants are basically going to look like a big bladder, urinary bladder. They can make your job a little harder, because now you have, in some cases, 14 centimeters of fluid between you and the breast tissue. So it can. A lot of implants are retromuscular, so they literally put it behind the pectoralis major muscle. Well, that makes everything just come out even more. So that's not a problem. But it's if the implant is on top, then yes, it could cause some difficulties. Not too much. And if they have an implant, then usually part of your job is to just quickly check the implant for any kind of leaks. Let's see, the mammary, I'll just write that. Mammary, it's hard to write all those M's in a row. Fibrous tissue, okay, so yeah, I mentioned this. The fibrous part of that is echogenic. The glandular part, the TCD, no, TD, damn, I did it again. TDLUs, I don't know where the hell C came from. TDLUs, oh, I still, gland, the TDLUs, the ducts in general, those are more isoechoic to the fat, or that's an S, or even hypoechoic. Okay, my must be at the wrong level for writing here. The retro mammary layer is just going to be more fat. Cooper's ligaments, thinner in general, thinner than the mammary layer. Chest wall, pectoralis major, pectoralis minor. Ribs can be either, if you're farther out, they can be calcified. If you're more medial, they could be cartilaginous, so they'll look different. And then lymph nodes. We will find nodes inside the breast. They tend to be small, less than 1 centimeter. Let's go ahead and write the nodes down. Nodes less than 1 centimeter, and that is intramammary, intramammary, and then greater than 1 centimeter or larger in the axilla. I will, yes, I'm going to write some other stuff down before we get back to our pictures. This is, so I named all of this that I've been writing down general appearances. And this is more general appearance. Prepubertal breast. If there is breast tissue at all, it is fatty. You really don't see prepubertal, you don't see the glands because they haven't been stimulated yet. But at puberty, the glandular tissue, glandular growth, young, nulliparous. Nulliparous, never been pregnant before. Probably mostly glandular. Now, if they're heavy, you know, if fat's going to go to the breast as well. But for the most part, mostly glandular. So you're not going to see a whole lot of fatty tissue. Oh, female and male. I don't like my male. There we go. Looks a little more robust now. Rudimentary ducts at birth. The neonates, in other words, at birth, especially the female, but males can get some breast issues too from exogenous, outside hormones. But the neonate can have nipple discharge, enlargement, oh God, Kurt, enlargement, sorry, trying, I don't know why it's so bad today. The neonate can have nipple discharge and enlargement. This is because of mom's estrogen. By the way, not in this chapter, but females can have ovarian cysts in utero and neonates as well for the same reason, estrogen. And then they go away. In both cases, this is a normal thing. It just goes away. And breast developments. Prior to 8 years, I mean, good Lord, I would think should be older than that. But I think any kind of breast development prior to 8 years is a precocious pupperty. They're going to turn into a puppy. Precocious puberty. And that could be anyway, wow, Kurt, wow. Anyways, hormone imbalance. They have a tumor, an adenoma or something causing the early development of female estrogens to occur, and then they have a precocious puberty that happens too young. So what do I want to do? All right, let's get away from writing stuff. Let's look at other images we have. I got a whole line. I didn't realize how many pictures there were until I look at that. Now, this whole line of images, we'll go through the first few slower, and then we'll speed up because there's just way too many. But what it shows here is, and never mind the multiple nipples and everything over on the side of your screen. So this is Radiopedia gave a full exam protocol. That's fine. Didn't say anything about the patient though. But as I went through it, I did not see anything that looked like this over here. All I saw was fat, fatty, fat, down to muscle. So I think it's either a pre or a post-menopausal patient. Let me get my other color here. Can I draw this? Yep. So in any case, obviously skin, fat, Cooper's ligaments can be seen. You can see different lobules. You can see that sometimes one of these lobules, as you're scanning through, can suddenly pop out and you're like, uh-oh, what's that? And it turns out it's just fat. We're definitely retromammary down here. Well, I should say muscle. And then rib and lung. Okay, well, they said left breast, and then they just used a body mark. The body mark shows that it's a left breast. They show, let me see how they were. Okay. I'm going to call it, from this image alone, I said, well, we could have written down 12 o'clock, because we're gonna use this as a clock face. We'll talk about that shortly. And radian. I could have, and rather than saying rad, I could have written sag, just like sag and transverse. So that's two different ways. Let's say or sag. So Yeah, okay. There's a lot of fatty tissue here, so we're probably, that seems like a good spot, or makes sense that that's where we are on the breast there. And then they did a transverse view, same spot, 12 o'clock. I said anti-rad. Like I said, we could have gone with a different nomenclature and called this trans. So same spot, same rib, same fat, we just went sideways on it. Now what this person is doing is just a full breast exam. On an older patient like this, I don't know why they did a full exam. I guess just because they were sick and tired of mammograms. Okay, here we cannot call this sagittal. We see by this body mark, this is your transducer, and what the patient or the technologist is doing is they're going to move this around the breast. But what they've done, this is rad, as in radian. And I don't know, what do you call that, 1 o'clock? Yeah, 1 o'clock, I guess. It really actually should be 2 o'clock if you're going to do should be 2 o'clock. Because what this person is doing, now this is like the liver. You don't give the doctor 800 images of the liver, but you look at 800 images. In other words, you scan all the way through that tissue. You scan all the way through that tissue, but there are standard images that they're going to give. And so this is what they're doing here. This is standard image. So we'll just quickly go through the rest of this column, and then I'll let you guys take a break. So 2 o'clock, rad. Oh, they didn't do the anti-rad, or I skipped it by accident. That's why I do that. Here we have the transducer is basically transverse, but we're actually going to call it rad. Going through, and as you see, it's all fat. I haven't seen fat in Cooper's ligaments. I have not seen any. And you could call this sagittal, but we know better. They're actually not doing sagittal and transverse. They are doing, they're doing rad and anti-rad. And now after the break, we'll break that down, the differences there. So just fat and muscle and rib, fat, muscle, rib, fat, muscle, rib. We're down at the 6 o'clock position. So it looks like they're really at the edge of the breast here, because it gets much thicker on the one side there. So they're really on the edge. Over there at the, 8 o'clock position, 9 o'clock position, still just, it's easier with my mouse. Fat, 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 fat. Axilla. So, actually, like I said, they're like snowflakes. Everyone is different. This person's nipple is either they're right off the edge of it, or it's so pliable and soft that it's just being squeezed out and we can't even see it. But there's just a little bit of fluid here. But this is fine. That's very little in the terminal lactiferous ducts there. That should be completely okay. But you can see that's basically the end of this patient's fibroglandular tissue. Another image of the nipple. The fibroglandular tissue is coming up to it, but we don't even see the nipple itself. So like I said, either they're just off to it, or that nipple is so soft that it's just squeezing out perfectly. And then, of course, if you're going to do a full exam, you're going to do the axilla. Absolutely, positively. You can see the body mark is going up into the axilla. Another axilla. Another axilla. But in all those pictures, there's really nothing to see. So I'm not even sure after I took them all down why I did, because it was an older patient with no fibroglandular tissue even left, all gone. All right, let's see. It is 1:54. You know what? I actually need a moment to organize here, make sure we're all good. Probably should have left more room up there. So let's go. Let's give us until 2:15. We'll take a break. And, okay. Wait a minute. If I hit. Well, I have these images up, but somehow I forgot to put them in my notes. But it's not exactly rocket science, which is fine. I'm surprised I didn't have these in here. So we kind of talked about general appearance, and then a little bit about development, and we'll talk about a few developmental anomalies. I mean, not much really to go on. Then we'll talk about the exam itself, preparation for the exam, how to place the patient, and then annotations, which is kind of a big thing. So some different ways of annotating, the different ways of doing the exam. So just slightly. Okay. So, and these polythelia, otherwise known as Marky Mark syndrome or Mark Wahlberg syndrome, because he has an extra nipple, is not terribly uncommon. And this guy, let's see, 2, 4, 6 nipples. Looks like I don't see any more, but he has these the ectodermal milk lines. You could have nipples, extra nipples, all the way from the armpit all the way down to the groin. And then if you do that, you could have a litter of children, which is nice. So if you want puppies. Congenital nipple inversion. The only reason to even really mention this is that some nipples are inverted. It's not to be confused with cancer. My writing's a little small on that, because remember, we did talk about skin retraction, and the nipple can retract as well. So if you have cancer behind the nipple, it actually pulls down as it's reaching out and grabbing tissue. It actually pulls down on the nipple. So, but if they've always been like this, well, no big deal. And polymastia, because not only can you have more than one or more than one pair of nipples or more than 2 nipples, which is not terribly uncommon. Polymastia is a little more uncommon, and there's a bunch of images on the internet. All of them were just weird, but Once again, polymastia can be up in the armpit. It could be, you could actually, I've seen on the internet, I saw a number of like bilobed breasts where it's a kind of breast on that side, or then a normal breast with the breast underneath that as well. And I even saw, I didn't open it up. I just saw the picture and I'm like, I'm not wasting my time. Apparently a nipple on the bottom of the foot, but I didn't even open it up because I don't think that's possible. Probably hurt to walk on. All right, exam. So that was just a little aside of crazy things you might see. In the exam room. Actually, we see all sorts of crazy things. We hear all sorts of crazy things, do all sorts of crazy things. Okay, for the exam, your patient should be rolled up onto their side. Patient rolled about 30 to 40 degrees with and you put a wedge or a pillow. Wedge under shoulder, or you put a wedge so they're comfortable and they can maintain one position. And the one obvious reason for this, especially with larger breasted or older women with very fatty and soft breasts, you don't want to be scanning off to the side of the bed. You want to be scanning on the patient. And what you do is, let me jump down to here. You want your nipple approximately centered. So in other words, nipple, more or less breast, not nipple, breast more like that. Anyway, you want your nipple centered. The other thing to do with the arm is raise above head. So, just basically above head, behind head, just they relaxed. If their shoulder is able to take it, and a lot of your older patients won't be able to do quite like that, but if they can, great. If palpable, have patient show you, and if it's palpable, palpate. Professionally. But you always want to, and this is anywhere on the body, if there is a palpable lesion, if there's something there that you're supposed to find and the patient could feel it, or they said, well, my doctor was able to feel it. Feel it. You have to. That's part of your job. That's what we do, as long as we do it carefully, professionally, and tell the patient what you're going to do. Two types of exams. The targeted, this is the more common. This is because of a palpated mass or a follow-up on mammography. Let's see. That's pretty much it. But remember, mammography is the number one. That's as of right now the gold standard. There's actually some other exams that they're doing that are pretty amazing. But as of right now, mammography is still the gold standard. That's what they're going to start with 9 times out of 10 or more than that. And so you're following up. You're not going for a fishing expedition. Let's see, we're going to put a no fishing sign up here, the little post. Grass down here, and there's your body of water. A little fish in it. No, no fishing. Unless you're asked to do a whole breast exam. Less common, but we do still do it. It could be because it's a young patient with very dense tissue. The fibroglandular tissue is so dense that there could be a mass right in the middle of the screen and the doctors can't see it because it's the same, I can't say echogenicity, it's the same radio opaqueness as the surrounding tissue, so they can't see it. So dense tissue. History of cancer, and so then you're just doing a node search. Just like on the neck, you might have had a thyroidectomy, and then you're going back a year later, 2 years later, 3 years later, you're looking at the neck, looking for any kind of lymph node increase in size. So you could just be doing a lymph node search after a known history of cancer. And just, let's just say, young and doctor doesn't want to irradiate. And the chances are overwhelming that a young patient, it is very, very, very rare, not impossible, but very rare for young women to get breast cancer. So doctors are a little more forgiving of doing a whole breast exam, skipping mammography, and just doing an ultrasound exam on younger patients because the chances of them having cancer are so small to begin with. All right. When do I talk about lymph nodes? I don't. So here I got things in my notes that I don't even have. Let's talk about lymph nodes real quick, just because I found these. These are great pictures. A through C, in other words, all of these, I'm sorry, the top row, normal lymph node. When we look at this lymph node, that is a huge fatty hilum. That is good. Nice thin cortex. This basically looks like a tiny little kidney, doesn't it? Well, if it was a kidney, it'd be sinus lipomatosis, and that would be bad. But it's not a kidney. It is a lymph node, and that looks good. So does this one. Big hilum, fatty hilum here. That all looks great. No real, they measured it. They measured it. That's fine. And slightly thicker on this side compared to that side, but I mean, it's nothing. This lymph node you barely can see. But when it comes to lymph nodes, that's a good thing. The next, D through I, mildly suspicious, very mildly suspicious, so probably nothing. And I didn't get into exactly why, but here, let's. So perhaps a little thick at this end, certainly compared to that end, a little on the thick side. Certainly a little on the thick side from here to here, whereas over here, not so much. Again, thickened. Really getting a little more hypoechoic. When the cortex, the darker it becomes on the screen, the little more concerned we get. Oh, we got a needle in this one, but this is anechoic, really here, and a little bit thicker, certainly thicker than this. Same thing, same thing. Left axilla. And then these are all definitely suspicious. On this one, Very little hilum left. Same thing here. Not much of a hilum. Both of them hypo, or well, all of them, all of these on the screen are hypoechoic, thickened. Down here, no hilum at all. Very concerning here. And this one's got a needle going through it as well. Agula. No idea. No idea what that means. Okay, good. Plenty of room down there if I need it. I didn't leave myself. Oh, I didn't. I forgot to mention this little picture here. Just an oddity. This patient, this person, did not have surgery. Well, it's so pixelated, I don't know. Did not have surgery. They were born without breasts. Bilateral amastia. Which I don't even know why we have to conclude, because we won't be doing breast ultrasounds on this patient. That's the one thing they get to look forward to, is a life free of breast cancer. I'm not making light of it, I'm just saying. Okay. So I've mentioned rad, anti-rad, sagittal trans. There are different methodologies. I like personally rad, anti-rad, but doesn't matter what I like. We do what we do at the, let's do light blue. Actually, it's stating black. Each one, we do the protocol, wherever we are working is the protocol we use. Each one of these black lines is a transducer position. The circle is the nipple. These lines are all sagittal. These are all radians. The nice thing about sagittal is that we're really, as sonographers, we're very much accustomed to this. And as we're going around the breast, we don't have to think about how to hold the transducer. It is held the same way every time. Let's do a blue color here. And of course, if you're going to take an image here in sagittal, you're going to take an image there in transverse, and there, and there, and there, and there, there. So sagittal and transverse. Now radians, on the other hand, as you're going around, this one could easily be confused as sagittal and transverse, but the next one cannot. Radian and anti-rad. So radian and anti-radian. The nice thing about radian and anti-radian is, especially with the radian, the black lines, the transducer, either the head or the foot of the transducer, the heel of the toe of the transducer is pointing towards the nipple. Well, that's nice because we have ducts coming in to the nipple from the outside. And so when you're in the radian position, you're more likely to find a duct in long. That's nicer. It's better. I find it's better. The problem with this is, both in radian and anti-radian, is the question of how do you hold your transducer. So I would say, let's call it some standard. You hold it standard there. You know, the head is at the head, the foot is at the foot, normal, no big deal. You get over here, now you're holding your transducer in the wrong way. At least as far as what we're accustomed to, it's the wrong way. So we're still going to hold it in the standard way though. Are you kidding me? I am recording. What is? Yeah, no worries. I'll get that in a second. I thought you were going to tell me I wasn't recording. Standard. In other words, when I say standard, all I'm meaning is that you're holding your transducer with the head. Well, that's what was put. You know what? Let's put an arrow. That's good. Forget the standard. That confuses things. Arrow. That's the arrow's going is the head of the transducer. At some point, you're not going to keep going until you're holding your transducer completely backwards. So at this point, what I do, and let's see, I talked to Melissa, and she does the same thing. Switch your transducer. And then at some point, once again, switch your transducer. So it does get a little confusing. Now, maybe other sonographers don't do this. It wouldn't matter that much if they didn't, or that I do and they don't, or I don't and they do, or whatever. Because breast tissue is breast tissue. It's got to look the same, no matter which direction you're holding it. Granted, if you're near the nipple, the tissue and the ducts tend to go up towards the nipple, and if you're holding the transducer one way and someone else holds it another way, their screen's going to be backwards. But I really don't think that matters too terribly much. But we'll look at this in class on the Phantom, and how at some point you just feel like you have to turn your transducer, otherwise you're just holding it completely backwards. And then as you're coming around, and you turn your transducer again. And the same thing with the Radians too. You know, you hold your transducer in the let's see, I'll just put an arrow again. It's the standard transverse, and then I'll come around this way, and then at some point I think I'd keep it. But over here, by the time I get down here, then I'm definitely turning my transducer around. That makes sense, because I'm not comfortable holding the transducer backwards. I'll probably change it here. You know what? I'm probably getting too much into something that you'll figure out on your own. Or your technologist, when you're out there, your preceptor would be like, your instructor's an idiot. This is how you do it. I can care less. Everyone's got a different idea of how to do it. So, but if they do call me an idiot, I want their name and number. Okay, so okay, we're good. Once again, accurate annotations, very important. Very important, because if there's something here and you don't say it's there, and in fact the doctor thinks it's here because you didn't give them enough information, that is major importance. So very important to annotate carefully with this. Anti-rad. Radial and short rad. Actually, it's over here. So radiant, what terminology was I using? Radians. This is really a mathematical term, right? Radian. You know, there's 360 in a circle, if you're going to measure out every degree, it'd be 360 radians of degrees. I don't know if I said that completely right. I'd have to ask my daughter, the math whiz. But in radial, really the same thing. And rad is just obviously shorthand. But I know the book says radial or rad and anti-rad. Oh, and A-rad is short for anti-radial. So that is fine to use on your annotations. So A-rad, the transducer, is held in this orientation. Radian transducer is held in a way that I can't draw. But anyway, in line with the nipple. So either in this case, probably the foot or the heel of the transducer is here and the head is here. And if you come around, then you just kind of turn your transducer around. Or not, I don't care. As long as you and your doctor agree with how you're doing it. So that's my preferred way. And of course, like I said before, if you just want to do I don't know why it's so hard to draw a straight line. Sagittal transverse, sagittal transverse, sagittal transverse. That's fine too. Whatever your doctor or your counterparts, your partners want is what you do. But I think they'll all agree with the clock face. Now, I know a lot of you are younger. You don't know how to read a clock. And I know this because I've had students already be like, I don't know where 10 o'clock is on the clock. I can't imagine it. And that's all right. It's just, we're in a digital age. People don't look at clocks anymore. So if you need to put a clock in your room, put a clock in your room. And it's going to be the same for both, but of course, let's say 3 o'clock for the right breast is medial. 3 o'clock for the left breast is lateral. So just keep that in mind. And so on and so forth with all of those times. What's your protocol? Rad, A-rad, sagittal trans, whatever. But this person, and there's actually another, well, no, we're getting into that. I went ahead earlier and I put a lesion in or a cyst in at 7 o'clock on the right. That doesn't give us a lot of information. Is that 7 o'clock near the nipple? Far away from the nipple? Is it shallow? Is it deep? So this isn't a lot of information, but at least we're starting to get there. On this person, I went ahead and put a lesion in at 3 o'clock. Left, 3 o'clock. Once again, not enough information, but at least we're starting to get in the right direction. Let's see, do we have... Yike. Let me just remind myself. Oh, no, it's down there. It's down there. I forgot. Okay. So now we have another added complexity to how we could do this. And that's 1, 2, 3, A, B, C. Right here, we only have 1, 2, and 3. I'll show you A, B, and C in just a second. 1, 2, 3 is going to, and for that matter, A, B, and C, is going to change depending on the size of the breast. A small breast is going to have a small 1, a small 2, and a small 3. A large breast, large 1, large 2. In other words, if this breast is twice as big, every one of these sections is going to be twice as big. but it still helps. I mean, you know, you just look at the breast and figure it out. So, and this is just like a target. There's, well, they have this separated out as nipple, which is probably correct. It is correct, actually, to have a nipple and then 1, 2, and 3, but we just call it 1, 2, 3. 1 is the closest couple centimeters, 3 centimeters, 4 centimeters, once again, depending on the size of the breast. In a circle, that's the area of 1. 2 is the middle. 3, we're now going all the way to the outside of the breast, medial, lateral, inferior, superior. We're not quite including axilla in this nomenclature. Same thing over here. We have a left breast, 1, 2, and 3. So on the right, and I wish they didn't do this down here, but we have a right breast, 5 o'clock. Well, yeah, because that's where 5 o'clock is on a clock. 3 o'clock's here, 6 o'clock's here. So that's 5 o'clock. 1, we'll get to the A. Oh, okay, I get it. This is confusing, guys. 1A rad, as in 2 different words, or ARAD. That was completely unnecessary. 1 ARAD. No need for that. This patient had a left breast, 1 o'clock. And yeah, because this is 12. Yep, this is 2, that's 3 o'clock. 1 o'clock, it's in the region of number 2. So it is a left breast, 1 o'clock, 2 ARAD. Over here, this is a mammogram. We're going to talk about mammograms good, not today, because I want to give you I want to teach you how to triangulate with mammograms, and I know how to do it, but I'm a little rusty. I want to make sure I know what I'm talking about. So I'm glad we're not going to get to that today. Okay, I thought we had, oh, I have some other books, some other images somewhere else. Okay. Well, I prefer the image on its side because generally the patient's not standing up while you're doing it. It's a little weird. The other part of this type of nomenclature, if it's 1, 2, 3, is now A, B, and C. This is entirely depth and has nothing to do with 1, 2, and 3. 1, 2, and 3 was, you know, 2 centimeter circle around the nipple plus, you know, and then beyond that, and then beyond that again. That's 1, 2, and 3. This is 100% to do with depth. So if we go, oh, do we have it? We don't. Well, that's good though. Let's write this nomenclature. A, B, C. It's the easiest. 1, 2, 3. So this person has a apparently echogenic circular lesion in the 1 region at 5 o'clock at a depth of A. Now we don't say, we could rather than say A, we could say 1 centimeter. It all depends on where you work and what they want you to do. But if we're going to use this nomenclature, this is how it goes. Let's see. So let's write it over here. Let's see. Right breast, and you probably don't have to spell out breast because everyone knows what you're doing. 5 o'clock. God, please, no one ask me if AM or PM matters. It really doesn't. 5 o'clock, what is it? 1A. So now we're adding 2. Oh shit. Okay. All right. Now I see what they were doing. They weren't wrong. That's okay. I'm fixing it now. 1. I wasn't looking at the entire image together. They are 2 different images. But anyway, okay. 1A. And if the image is taken, yeah, see, this is the part we don't really know. The ARAD or RAD. It says ARAD. Let's go ahead and put our transducer in. Sorry guys, I just realized I kind of screwed up, but not a big deal. Not a big deal. There's my transducer. It is in the ARAD position. Right breast 5 o'clock, 1, location 1, depth A, ARAD. If I change my transducer, like my very next image, I change my transducer position to that, then my next picture, whoops, is going to be right breast 5 o'clock, 1A, because that doesn't, the 5 o'clock doesn't change. It's not going to change its clock position. The 1 is not going to change. The depth isn't going to change, but my transducer changed. And so now I put RAD because my transducer is in that position. So realizing now what they were doing over here, they were looking at both pictures, and I'm an idiot. Left breast, 1 o'clock, 2, damn it. Got in the habit of doing 1 o'clock. 2 o'clock, because it's, yeah, it's time to pretty much finish this section and then go take a nap, right? It is at 1 o'clock. It is in the 2, I can't draw anymore, 2 position, B, depth B, and they said ARAD, so let's just go ahead and quickly draw in an ARAD. They must have been holding their transducer like that. ARAD. And I should never have erased that or that. That's okay. We're all human. And then just the last is the simplest. So if your mind is spinning a little bit with that, this part is easy. It's kind of like the abdomen. You can go through the 9 quadrants, or you could just make it easy and say, you know, in the case of the abdomen, right upper quadrant, left upper quadrant, right lower, left lower, upper outer quadrant, UOQ, upper outer quadrant, UIQ, upper inner quadrant. So, oh, by the way, this has to be this is a right breast. I drew this in. This is, remember, This is the tail of Spence. Small-breasted women barely even have a tail of Spence at all. Larger breast women do have a tail of Spence. So upper outer, upper inner, lower outer, lower inner nipple. So 4 quadrants plus a nipple region or an areolar region. The 50%, that's the amount of cancers. So the majority, or certainly the plurality of cancers occur in the upper outer quadrant. The next highest number is this is really technically called retroareolar. The retroareolar. That's why I'm telling you guys, that's no small number. You roll the nipple. You got to get under that nipple and get a good look at it, because that's where the second, that's a small, when you consider it's the smallest area of the 4, of the 5, I guess. It's the smallest area, but it has the second most cancers. So in a way, as far as volume goes, it's the number 1 area, because it's a smaller volume and it has 18%. So in any case, important. It's all important, but that's important as well. So let's see, I'm going to quick look at my notes. Patient, rolled, Sag trans, rad, arad, quadrants, and axilla. Okay, yeah, now let me just add that one little thing, not a big deal at all. In all of these, whether your location just does quadrants, whether they do ABC 1, 2, 3, and if they don't use ABC 1, 2, 3, you know what, I'll tell you about the alternative to ABC 1, 2, 3, but no matter what you're doing, you also have this region. You have to look at the axilla. Unless you're doing a very targeted, the doctor says, look at this and only that, then that's all you do. You don't go meandering into the axilla. It's not your business. But if you're doing any kind of a full breast exam, the axilla, it's like all this, image here, a full exam, and then axilla added on. Just like this long list over here. Let me quickly tell you, if you don't use 1, 2, 3, A, B, C, then it's simply like, okay, you don't use that. What do you use? You use depth. And centimeters from nipple. Oh boy, I need to zoom in here. In other words, let's see, let's just, let's use this one right here. This guy right here is now a lesion of the right breast, 10 o'clock, because you're probably still using that. You really should. Upper outer, the quadrants are not very descriptive, or not descriptive enough. right breast, 10 o'clock. Let's see, 4 centimeters from nipple, FN from nipple. How would it, 4 centimeters in those, and well, here. And it was, let's see, it was right breast. Let's say it's right there. And so let's see, 1, 2, 3, 4, let's say 5 centimeters. We'll make her a, yike. We'll make her a kind of a big girl. Um, 5 centimeter depth. So that's yet again, another alternative. So just remember guys, you're not going to be using all of these. You have to be familiar with all of them, but you're either going to be doing sagittal trans, rad, arad. You're going to be probably using a clock face, but maybe not. Maybe you're going to use upper outer quadrant. You're going to be, let's see, you're going to be using either ABC 1, 2, 3, or you're just simply going to say how many centimeters away from the nipple and at what depth it is. You're not going to be using all of these. You're just going to pick one, or your preceptor is going to tell you which one that they want you to use. And that's the way you go. Okay. Oh, we only have like an hour tomorrow, right? Oh, shoot, we're not going to finish tomorrow because you guys have a test. I know. No, she's not here. I know one of you is always going to ask, how many questions? How many questions? I was given from the publisher 17 questions. So I'm going over them now. I already removed one, which I thought was horrible. It didn't even make any sense to me. So and I'm now down to 16 questions, which means I'm going to add at least 4. Hopefully I'll get to maybe 25 questions. I could always, if I want to add questions, I'll put a picture in and reference it for multiple questions. So not too hard of a chapter, not too big of a chapter. So 1.5 minutes per question. And it's, the whole chapter 15. So be familiar with your chapter. I know it's a hard read. I know these aren't particularly fun to read, but you should at least try, and at least of which be familiar enough with your chapters so that you can find things easily. But that's it. Oh, let's see. Let's see. Stephanie, are you busy right after class?
No, sir.
Cool. We'll hang on to you. Although your voice didn't come across particularly well, so we might make a phone call, but we'll see if we can just keep you on Zoom. All right. Did I already turn this off? I did not.